Does it feel like it's getting caught on anything? Do you feel any creaking or crepiness with it? Do you feel any grinding when you move it from side to side? You're also going to come down on the medial and lateral condyles of the femur, and you're going to palpate them as well. How do they feel? They should be smooth. They should be like the surface of this table. They should be smooth. There should be no bony obstructions. There should be no bone spurs in there. Then you're going to come down into those plateaus, those tibial plateaus that we talked about, the medial and lateral plateaus. Remember, those plateaus are where the meniscus lie, and that's where they live. And you normally shouldn't feel anything, but sometimes if you dig your thumb in there and you move from side to side, you might feel some clicking or some motion in there, and that could be a sign that meniscus has become detached. Sometimes when you come out into the more medial posterior aspect, in here you might feel a bone spur. And usually with the knee, and because of the Q angle of women, and just because this portion of the knee is more prone to trouble, you're going to find arthritis, especially degenerative type of arthritis, more medially than laterally. So you might feel some abnormalities in the bone itself. Like I said, bone spurs. Sometimes one, if you compare from side to side, you'll be able to stick almost your whole head of your thumb into that joint space. The other side you might not be able to because that joint space is starting to diminish. You're then going to come out to the sides, and you're going to palpate those medial and lateral collateral ligaments. How do they feel? You should be able, and sometimes if you move it from side to side, you should be able to feel in between the joint space, and you should feel that flat band that's in there. You know, also with this, you want to ask the patient, is there any tenderness when I do this, any pain or tenderness? And you're going to come back down into the front of the joint line, and with your fingers, also your fingers in the back are palpating the posterior aspect. Sometimes there can be a cyst, like a Baker cyst, or what's called a popliteal cyst. Baker cyst sometimes is an inflammation of the bursa sac, and it's going to almost feel like a rubbery Super Ball type of consistency. And that, I guess Bakers used to get them for being on their feet so long. I don't know how, or Dr. Baker named it after himself. Mm-hmm. But, you know, that could obstruct the range of motion too. If they try to, you know, flex their knee all the way up, depending on the size of that Baker cyst, it might not be able to do that. You're then going to come down to the front. You're going to palpate. So we palpated that kneecap or that patella. Now we're going to feel this tendon. How does it feel? Is it tender to them when you do that? Do you feel any resistance when you push into that tendon? This tibial tuberosity that we talked about, where that main tendon comes together and inserts, is there any tenderness there? I put up there, especially in children, tenderness of that tibial tuberosity, or if you notice any redness, or any, you feel any heat or any swelling, it could be a condition called Osgood-Schlatter's. And what that means is, sometimes where that tendon inserts becomes detached, and there's different degrees of detachment. Sometimes it just never fully attached to the bone. Sometimes it's become avulsed off the bone. It's kind of like a growth defect, but it's just something to be aware of. Very rarely, but sometimes if it's a child and they have that tenderness, sometimes if you do range of motion, and when we get into range of motion, active and resisted range of motion of the knee, you have them lock their knee out and try to, you know, don't let me push down, keep this up, don't let me push down. They're not going to be able to do that because that tendon's not attached. That's an indication of possibly that Osgood-Schlatter's. And that's when X-ray would come into play, just to evaluate how severe is it. Is it you know, your mild, your moderate, your severe type of Osgood-Schlatter's. A lot of times it's just about, there's those Chopat braces. You ever see those braces that you can put over there to help secure that tendon down? You know, rarely, very rarely do they have to do any surgeries. But also, you know, while I have you down like this, we're going to go over range of motion of the knee. So with the knee itself, with extension, range of extension is when you're bringing the knee or locking the knee out like this. Normal extension in patients should be about 0 degrees, meaning this is 0 degrees. It shouldn't go any further than that. Some patients, especially some women, have laxity of the ligaments, so they might be able to go, you know, maybe 5 or 10 degrees in the opposite direction. They really shouldn't be able to though. So you're going to have the patient extend their knee. You know, also note if they have any pain or tenderness when they extend the knee, then you're going to extend their knee. And again, we're going to do this side to side, you know. Is there any pain when I do this? There's also internal and external rotation with the knee. And typically you're not going to be able to have them do that actively. It's just a hard motion for them to do. So you're just going to see if, you know, how's their, you know, external and then internal rotation. Is there any pain? Is there any clicking with that too? That's the other thing you're trying to assess. Especially when you do your passive range of motions. Keep your hand on that area, especially on the patella, because sometimes you're going to feel sliding or grinding in the patella when you do it. And that's important. We talked about, and when we get into stuff next week as far as tracking issues, that's an important thing that we're going to have to assess. Because sometimes the knee is supposed to track right in the center here. And sometimes because of muscle deficits or injuries, it's going to either track medially or usually it's going to go off to the side and just not hit where it's supposed to hit correctly. If you turn, can you lay on your stomach here? As far as flexion, you're going to have the patient, so with this heel, try to bring it all the way to your butt. You're going to have them do that. Usually with knee or terminal knee flexion, it should be about, you know, some texts say about 135 degrees that they should be able to do that. You're then also going to do it yourself. You know, how far can you go? Can you go a little bit further? Does this cause any pain? Sometimes you're going to find that when you do it passively, you're going to see the hip roll up a little bit. That's usually an indication of some of the muscles in the anterior portion of the thigh are tight, and that's why it's rolling up. And again, we're going to compare from side to side, affected side to not affected side. And his range of motion is pretty good here. Do you have any knee problem?
A little bit, yeah.
Range of motion is good. And then again, you're going to do kind of your resisted range of motion. So I'm going to have you push your leg down into my hand and don't let me push up towards your head. And just see, and this is also a muscle test for, you know, rectus femoris or some of those muscles too, where you can also have them go the opposite way. This is for hamstrings. Push your leg into my hand and don't let me push down. And just see if there's any weakness or any deficits there. And while you have them here, you can also just do a little more thorough examination of the posterior aspect of the knee. Again, looking for that Baker cyst. And you can also, there's an artery in here, and you can try to get the pulse. Sometimes, you know, if you can't get a pulse, it could be an indication of arterial insufficiency. You know, there's some problems with circulation. I would also, while we're down and I have them like this, we talked about trigger points in the gastroc muscle. You know, when you palpate the gastroc, start at its origin and work your way all the way down into the insertion and just compare from side to side. Has everybody palpated a trigger point before or know what a trigger point feels like? We'll try to find some, if we do. They feel, imagine about the diameter of like a marble, usually. About that size, you're going to find like a little nodule like that in the muscle itself. It's going to be pretty hard, and usually it's going to be very tender. And most of the time it's going to refer pain, and depending on the different regions that it's in, depending on the different muscle groups that it's in, you're going to have a very distinct pattern. You know, sometimes in the gastrocs, if there's a trigger point, it's going to refer down into the bottom of the foot. You know, when we talk about shoulder issues, it can refer down the arm. Now remember, we talked about that Thompson test. We talked about Thompson test to see, what are we checking for with Thompson's test? Yeah, like a rupture. So you're going to grab onto his calf. See how his foot moves? That's good. That means that that's intact. If there was a rupture, you're taking over the action of the gastroc muscle. So if there was a rupture of that tendon, there would be no movement there. With that Homan's test, what are we looking for with Homan's test? Or Homan's sign?
Blood clot.
Blood clot, or thrombophlebitis. Again, you know, you're passively dorsiflexing the foot, and you're going to put some pressure into the mid calf. And again, if that